Let's move on to the two major topics I want to cover today, invasive fungal infections and then followed by CMV. Let's start with your perspective, Mark, on what's the morbidity, the mortality that's associated with invasive fungal infection post-transplant?
So obviously it's extensive, and in fact that was always one of the major impediments to transplant. I mean, you know, we were from the time when patients died of invasive fungal infection following transplant. All we had was literally standard formulation amphotericin B, the dreaded amphotericin, which if it didn't kill the patient, you know, was trying to kill the mold. It wasn't particularly effective at that either. So fortunately, the world has changed. We still have to pay attention to it, but I will be very honest, with the agents that we have available now, paying close attention, it's easily managed. You just have to be aware of the problem. The mold-active azoles has been an enormous advance in the field.
And I imagine some of that comes from the prophylactic measures that we're taking. Would you like to review for us what are current guidelines on prophylaxis?
Yes, absolutely. So first, you know, absolutely the morbidity and mortality from invasive fungal infection, either mold or yeast, it's still not uncommon. We're still seeing it. But with the prophylactic regimen that we have available over the past, probably now it's been almost 15 years, where we have the triazoles on the market, and we try to first stratify patients into low risk versus high risk, and depends on their risk factor for invasive fungal infection, and based on NCCN guidelines as well as the IDSA guidelines, we try to stratify on the low risk where they can probably get away with fluconazole, for example, to prevent yeast infection or invasive candida infection with high dose fluconazole, versus even micofungin as based on guidelines, one of the echinocandin, if they cannot take oral fluconazole. So this is for the low risk. Now the high risk is a different story, because at that point you need to prevent, it will try to prevent a mold infection, which is mainly, most commonly, is pulmonary invasive aspergillosis usually, and then later on probably mucormycosis and fusariosis. So the mold-active agent, actually, based on the guidelines, the recommendation is to go with posaconazole. There's good data published over the past few years about posaconazole compared to fluconazole versus itraconazole, and it worked much better to prevent invasive mold infection. So, and that's what most centers probably are doing, but there's other choices also based on the guideline, not probably number one or maybe second line, like voriconazole or even echinocandin sometimes, when you have side effect from all the triazoles.
And so I've noticed voriconazole has gone generic now, and so there seems to be a push from third-party payers that patients should be on voriconazole.
Yeah.
But to be honest, we've gotten more used to using posaconazole now because it's an easier drug to use.
I'd like the two